Good morning, ma'am, and good morning, ma'am. Morning sessions are always a challenge, especially on weekends, Saturday and Sundays. But anyways, it's great to have, even if we can drive in a message to one person, it's I think, a job well done. The reason why we delayed is because we have two of our speakers yet to come. They are on their way, Dr. Manpreet and Dr. Mohita. So thank you all for coming. Today we'll be speaking the ICs on optics and mathematics made easy for a cataract and refractive surgeon. Special focus on certain conundrums, in terms of what imaging do we use, what scenarios do we use in imaging. So a wonderful series of talks ahead of us. I'll be speaking on tomography and epithelial mapping made simple. Okay, so the challenge I think lies in the fact that we have a lot of instruments. Some centers might have a Scheimpflug, some centers might have a slit scanning, but I think the general consensus in terms of which tool do we use, at least in refractive practice, it is the Scheimpflug. Now, why is it the Scheimpflug? It's not about just the cost. The fact that it delineates posterior elevation very well is important, and that also has a role in planning cataract surgeries better. And how does that happen and how do we proceed with that is what I would go in. And I think it's understood now that cataract is a refractive surgery. And premium, it's not only about the premium patients, it's even a simple cataract surgery. You need to optimize outcomes. And that's where the role of tomography into our cataract practice is something which is very important. Now, why a tomographer and how do we utilize tomography in our cataract practice is something which is important to understand. Now, there are four important effects. When we are looking at curvature, it's just not putting in K1, K2, and looking at the pachymetry, etc. It's about optimizing which type of maps we use. Now, if you're looking at any sagittal curvature map or an axial curvature map, there is a concept of refractive effect. What is refractive effect is ideally, the radius of curvature in a sphere is equal at all quadrants, or overall it's uniformly equal. By that logic, curvature also should be equal, right? So if it is 43 in the center, it should be 43 in the periphery. But why does that not happen is because of an effect of something known as spherical aberration. Now, the understanding has changed in IOL formulas is because a normal scenario, anterior and posterior surface of the cornea is actually constant, posterior surface being 82% of the anterior surface. So thereby, in scenarios where it's a virgin eye, it does not make a difference as to what value you take or what reading you take. But in scenarios such as a post-refractive patient, this ratio can get altered. So that is something we need to remember. The refractive index, traditionally Placido or any keratometers use a refractive index of 1.3375. But actually it is 1.332. I mean, you don't need to remember the values, but what you need to remember is that there is an inbuilt correction in these IOL formulas to factor that change in the refractive index. And also the location of the principal planes. Though it is not very significant, the principal meridia of the anterior surface of the cornea is in fact different from the posterior surface of the cornea, and how it actually is extrapolated to a practice is something which I'll just speak to. Now, this is, I think, a commonly used map which you see. This is the 4 map which you see on a pentacam. Any Scheimpflug tool will have the classical 4 map, which gives you the curvature, which gives you the elevation, anterior elevation, posterior elevation. It also gives you the values in terms of keratometry. But what keratometry value do we use? I know this is where the concept of sim K or simulated K comes into being. Now, if you look at the central 3 millimeter zone, I don't know if you can see. Yeah, if you look at the central 3 millimeter zone, the average of the keratometry values here is what is normally taken. Now, the challenge is the fact that you need to understand that the keratometry values taken are not, it's not a simple average. What a tool or any tool like a pentacam does is they look at just certain amount of points and extrapolate the remaining. So if you get a 47, it actually may be just 46.98 or a 47.26, but just for simplification they extrapolate it, and that 0.2 or a 0.1 diopter change or a difference generally does not make a difference in the outcomes when you're looking at refractive surgery maps. So I'll try to simplify what maps there are. Now, whenever you're looking at a sagittal curvature map, you need to understand that, if you see, these readings are actually the same throughout. Why is that so? Is because this map does not consider or take into the effect of the refractive effect which I spoke about, which is a spherical aberration. So the first mistake people do is axial and sagittal curvature maps cannot be used interchangeably. Sagittal curvature maps consider curvature, but consider curvature without spherical aberration, and therefore you get the keratometry which is kind of uniform from the center to the periphery. The refractive power map, on the other hand, incorporates the effect of spherical aberrations. So if you see, the central values are different from what you see as you go towards the periphery. So that is something you need to remember. The true net power map. So these are the maps. If you're talking about the sagittal curvature, you're talking about the refractive power maps. In practicalities, these are not something which we use. To summarize it, we generally use SIMK or use EKRs, and these are the ones or the keratometry readings which are finally put into IOLPAR calculations, simply because of the reasons which I will elucidate now. Now, the true net power looks at the anterior surface of the cornea as well as the posterior surface of the cornea. I spoke about the fact that ideal scenarios, anterior and posterior ratio is constant, and it can change in scenarios like a post-refractive surgery. So in those IOLPAR formulas, this practicality does not hold true. But the challenge is because it's using a refractive index of the cornea, refractive index of the aqueous humor, what invariably happens is this cannot be incorporated into IOLPAR formulas because they're using a refractive index of 1.3375. So, morally we are talking about true net power being good enough, but actually in practicalities we don't use it. EKR is a wonderful option. I was speaking about EKR options which are seen on the Pentacam. What is an equivalent K-reading map is the fact that it gives you the range of the dioptric distribution of the keratometries over various zones, 1, 2, 3, 4.5, 6. What is also useful is that it could be used in formulas because it factors into the refractive index of 1.3375, and also it calculates for an adjustment for both the anterior cornea as well as the posterior cornea. So that is something which is very important. So I spoke about those 4 effects: refractive index, refractive effect, anterior posterior, and the location of the principal meridia. Overall, EKR kind of looks into it. So if you see people planning multifocal IOLs, you look at an EKR, look at the EKR in the 4.5 millimeter zone, look at the distribution of the keratometry. So if you see, this is not a very widely distributed keratometry, so it is a compact, not something which is irregular, and these patients would do well. So why do we need it in such scenarios? Is because one is obviously planning multifocal IOLs. The second thing is, even for planning a simple case, it need not be a premium IOL. Optimizing outcomes in terms of post-operative quality vision is also important. So you get a patient who maybe has a focal scar. What you could do is look at EKR, the distribution of the EKR over the 4.5 millimeter zone, but also to summarize, there are some other aspects of values which are seen. There's something known as EKR 65, which is actually 65% of the mean values. There is something which is known as the global mean EKR, which gives you an average of the EKR. So what happens is, in a regular cornea, the EKR, the mean EKR, as well as the EKR 65 generally tend to be almost or very less than 0.5 diopters, and that is what is important in these cases. The total corneal refractive power map again uses ray tracing. It accounts for, I spoke about refractive effect, inclusion of the anterior and posterior surface. It also looks into the effect of the principal meridia both in the anterior and the posterior cornea. But again, more realistically, it generally does deviate from the SIMK, and therefore it cannot be used. So I'll be going into aspects of epithelial mapping before I kind of summarize what I spoke about. So I'll just try to cut down for want of time. Now, epithelial mapping is a challenge. Why is it a challenge? Is the fact that topographers do not factor for epithelial changes. If you're looking at a pentacam, they assume that epithelium is irregular, and that invariably can be a confounder. Yes, okay, can be a confounder. So it's important to understand that epithelial mapping tools such as MS39. I know not all of you will be having an MS39. Any tool, it need not be an MS39, an anti-segment OCT. It's very important to incorporate this into your existing practice. Okay, so you get scenarios where corneas appear to be suspicious. You get an area which is focal steepening. It would be prudent to do an epithelial mapping in those scenarios, simply because sometimes patients do present with ghosting or glare or visual disturbances, and you get a picture such as this. In fact, the epithelium was the culprit. If you see the area, of the steepening coincides with the focal area of an epithelial hypertrophy. Now, another aspect is also in terms of planning for surgeries. One is preoperative epithelial mapping. The second thing is post-operative outcomes. So always treat ocular surface. Epithelium is a very good indicator for the ocular surface health. That is prior to planning. Post-operatively as well, patients coming with glare, halos, the concept of epithelial regression. Therefore, epithelial mapping is something which is very important in those scenarios. Pseudo regression. So you get patients who are keratoconic. They have two time points. Sometimes you see pachymetry is stable, but there is steepening. In those cases, it's actually not true progression. It could be epithelium remodeling, which could be one of the causes in such cases. So to summarize overall, tomography is important not only for refractive surgery. You need to customize your use for tomography in IOL practice, in cataract surgery. Epithelial mapping is a useful tool, not only in refractive surgery again, even in outcomes post, cataract or post refractive surgery. It's important to at least have one device, any ASOCT, to kind of simplify or help us in this. So we'll move ahead with the course. We'll speak. Next speaker is so Dr. Pooja has an IC at the same time. Therefore, my colleague Dr. Reshma will be speaking on unhappy patients. So a lot of cases, in refractive surgery, you get patients coming in with 6/6. They have good vision, but they're not happy. And how do we actually approach these patients? Though it might form maybe 10% of our refractive surgery practice, these are the patients who take a lot of chair time. So it's important to understand as to what could go wrong and how do we approach these patients. So Reshma.
Good morning, everyone. So, as Dr. Gairik said, we'll talk a little bit about how do we manage unhappy patients in our practice. So, let's see a few case examples. So, here was a 33-year-old lady endodontist by profession who had a history of LASIK done elsewhere 8 years back. She was diagnosed with a post-LASIK ectasia 5 years back, and she had undergone cross-linking for it elsewhere, but she was not happy with contact lenses. She presented to us with history of glare and scattering of images in the last 6 months. And on detailed history, she said that the onset was sudden. Now, the image that you see here is the image which is drawn by the patient. So she carried a picture of it to us, and that is why I've put it up here. So there's always more to a story than the body can see from the fence line, is what they say. So what is important is to talk to your patient and not to your patient. So you need to find out the onset, for how long they have been having the complaints, if there has been any change in the routine practices, or if at all there are any recent issues that the patient has been bothered with. So, on prodding further, she confessed to having undergone some emotional upheaval in her personal and professional life. And on examination, the dry eye evaluation was normal. This was her refraction that it showed up with a minus 5.5 cylinder in the right eye, and similarly so in the left eye. But are we also missing anything else here? This is one of the papers that we have published in the past about binocular vision assessment in refractive surgery workup. And we have a dedicated orthoptics department in our hospital, and we subjected her to a detailed NSBAVA assessment. And we identified that she had a pseudoconvergence insufficiency. So what are we looking at? So this was a case of post-LASIK ectasia status post-cross-linking with a pseudo-convergence insufficiency and some psychological factors playing in because of the recent history that she gave. So she was advised counseling with home and office-based exercises. This is another study of a 32-year-old lady who presented to us with history of LASIK done in the year 2019 and with a post-LASIK ectasia, complaining of blurring of vision with ghosting and scattering of images. She showed a refractive error of a +2 sphere and a -2.75 cylinder in the right eye and a 1.25 sphere and a -1.5 cylinder in the left eye. So this was what her pentacam comparative maps looked like between September 2022 to February 2023. And while it was well within the repeatability range and while we could see progression, we also have the PSOCT, which images the collagen, and that documented progression also. So when we subjected her to aberrometry, we found that the internal aberrations were on the higher side along with that of the corneal aberrations. And we also subjected her to a detailed orthoptics evaluation. And she had a right exophoria for near, along with the accommodative facility, which was found to be difficult in plus, and the Virgin's facility with a binocular prism, and the NPC was also less. So she was diagnosed with a convergence insufficiency and was advised office-based exercises for 10 days with taper. So what did we infer from the orthoptics evaluation? So we identified that the ghosting of images that she was having was not just because of the ectasia, but also because of the convergence insufficiency. So to go back and to summarize, this patient gives us the take-home point that while she had a post-LASIK ectasia and showed progression in the PSOCT as well, we shouldn't be ignoring the orthoptics part either. So how do we manage this case? So she was subjected to a contact lens trial, a close observation, orthoptics exercises, and intacts with a laser-based cross-linking later. So this is another case of a 35-year-old male patient who had undergone LASIK a month ago, and he had uniocular blurring of vision in the right eye. So while his vision was 6/6 and he showed up plano on the refraction, the topography was absolutely normal with a normal anterior segment examination. These were the total eye aberrations, and he was subjected to an orthoptics evaluation also. But what is important was to talk to the patient, as I said. So the patient could not see clearly, and he had a history of a panic attack, and he gave history of having a job which was he did night shifts basically because he was working for an international organization, and there was insomnia. He gave history of sleepwalking and marital issues in his newly married life. So he believed that it was all because of the surgery, but we also need to remember the point that there was stress playing a role. So he was subjected to a detailed counseling in the presence of close family, explaining the impact of a deranged sleep cycle on the ocular health and the impact of anxiety on vision. And we referred him to a neurobiologist for the same, and he was started on anxiolytics. After 3 months, he gave history of improvement in the visual symptoms as well as the anxiety-related symptoms. So I would like to introduce our approach to unhappy patients, wherein if at all a patient presents to you with glare, halos, and difficulty in vision, after you have done a detailed history and a vision assessment along with the dry eye workup and the topography, you would go ahead with a contact lens trial, and if the patient improves with the symptoms, you can possibly prescribe the same. But if at all there is no improvement in the symptoms, you need to go and check the lens, if at all that patient needs a lens-based procedure. But if the lens is also not the culprit, then in that case, an orthoptics evaluation becomes mandatory in order to identify whether the patient has any accommodation or convergence anomalies, and also if it is a true regression, and accordingly plan the treatment. Thank you for your kind attention.
Thanks, Dr. Reshma. So she covered important points. We obviously are now going to jump to orthoptics and personality evaluation. So it's important to kind of sequentially evaluate these patients. So 6/6 glare halos, take a lot of chair time, always scribbing. Don't directly jump into imaging. Take a detailed history. That's something which is very important. Do a cycloplegic refraction. Always check for the ocular surface. Epithelial mapping is important. Always rule out ablation, centered, decentered ablation. That could be one of the reasons. Zone, small zone, large zone, that is something also very important. Eye trace, aberrometer, she's kind of highlighted that very well. Is a very important armamentarium. It kind of tells us as to where exactly the problem is. You're looking at corneal aberrations, you're looking at a problem internal. So remember, internal aberrations is not always lenticular. Anything from the posterior surface of the cornea backwards is internal. It can be predominantly lenticular. So it gives you a fair idea about whether it is related to what she spoke about, is accommodation or non-strabismic binocular vision anomalies. That kind of can throw up as a large amount of internal defocus. The second, it's only after this that you should be adding to or looking into these anomalies what she spoke about. I know there are practical challenges in looking at personality. You cannot be giving a questionnaire to address their psychological status, no doubt. But that is something which I think can be elucidated with a detailed history. No doubt, she spoke about the patient being completely normal. Uh, Everything else was ruled out. Tomography was normal. They did a detailed orthoptic evaluation, and there were additional stresses in his personal life due to so many causes, and it's in those scenarios there the influence of personality can bear fruit on post refractive outcomes. So this is something we have published a couple of years back in JCRS, which have kind of documented the four strata of personality. There's something known as sanguine, choleric, melancholic, phlegmatic, and generally the personalities which have problems, where generally they have an exaggerated response or to any stimuli, and in those kind of scenarios it is the choleric, it is the melancholic, which you need to kind of stratify and look at that. So that is something which is important when we are kind of stratifying the patient. So thank you, Reshma. Any comments or questions? Yeah. Hmm. Yeah.
What is the basic dry eye workup that you would do for, because not everybody will have these machines.
No,
so what would you give in 3 pointers what one should do as a part of the workup?
you're doing a Shermers, you're doing the tear film, and a meibography could be added to it. So you need not have a meibographer. At least any infrared autorefractometer also can be used as that. So I'm talking about scenarios where you don't have any other armamentarium. So that can overall give you a good idea as to how the ocular surface is.
So what I get is it's very important to do a dry eye workup for all refractive patients. Nonetheless, it should be, or even cataract, not only refractive, refractive LASIK, even refractive
I
cataract.
think a basic screening should be done at the outset. So you can get a fair idea clinically as well. You're looking at the ocular surface, the meibomian gland expressibility, dropouts, blocks. That is something which I think 70% could be judged clinically. You don't need.
I think it's a great point, because I don't know how many of there's a small group here, but how many are actually doing dry eye workup for all our cataract patients? Are you doing so? Dry eye workup? No, that's the thing. So I think that's a great point, because not many people will be doing dry eye workup.
Yeah.
So it's a great point to bring about. Second, I wanted to ask is, do you do cyclorefractions for myopes?
It is, to be honest, you need to be doing cyclorefractions, but
because I burnt my fingers with accommodation.
Yeah, so it could be a part of the workup. What I would suggest is also add an NPA NPC to your workup for pre-operative workups of refractive patients.
So again, practical thing that, because you brought it about so nicely, there are two things which I think which should be done. Is one, we dilate all our patients.
Yeah.
So it's best to do a dilated AR. Because
that is done, but so cycloplegic is
so cyclo is not practical, no? Yes. Because this patient wants surgery tomorrow.
Yeah, that's
if you delayed for 3 days, he's gone to the competition.
Yes. So those are practical challenges. I mean, so maybe not cyclo, dilated refraction when you're getting
just an AR documentation would be. But there was a great point you brought about.
Thanks, Dr. Samresh.
Thank you.
I think we'll move ahead. I think we have Dr. Manpreet Kaur. She's currently at RP Center at Cornea Cataract and Refractive Services. Thank you for being part of the IC. She'll be speaking on the role of posterior corneal astigmatism in cataract and refractive surgery. So I think a lot of groups abroad speaking about PCA, whether it's important, not important, what is our interpretation of posterior corneal astigmatism. I think that is an important point, and I think she'll throw light on that.
Thank you, Dr. Gairik, for making me a part of this very interesting IC. And I'll be speaking on role of posterior corneal astigmatism in cataract and refractive surgery. At the outset, there are no relevant financial disclosures. So the conventional keratometry that we have all read about measures only the anterior corneal curvature. It assumes a fixed ratio between the anterior and posterior corneal curvature and uses a keratometric index of 1.3375 to calculate the corneal power. It does not take into account the corneal thickness or the influence of the posterior corneal curvature on the total keratometry value. So any ideal IL power calculation formula will give you the magnitude of IL power. In case it's a toric, the toricity and the axis. This should take into account surgically induced astigmatism, effective lens position, and the posterior corneal curvature as well, which we'll be talking about in this presentation. So the anterior corneal curvature acts as a plus lens, may have with the rule or against the rule or oblique astigmatism, which shifts with age. In contrast, the posterior corneal curvature acts as a minus lens. It is generally steeper in the vertical axis and causes against the rule astigmatism. So it's steeper along the vertical meridian in around 80% of cases. The mean value of against the rule astigmatism induced by the posterior cornea is around 0.3 diopter to 0.5 diopter, ranges from 0.26 to 0.78, and there is no specific correlation between the anterior and posterior corneal astigmatism. It's moderate if with the rule astigmatism is present in anterior cornea. If oblique astigmatism is present in anterior cornea, you cannot really correlate it with the posterior corneal curvature. And if against the rule astigmatism is present, there is absolutely no correlation. So what happens to the posterior corneal astigmatism with age? Anterior corneal astigmatism shifts from with the rule to against the rule, that we all know. However, so posterior corneal astigmatism remains constant. So if around 80% have with the rule in their 20s, around 7% will have against the rule anterior corneal astigmatism. By the time their patient reaches their 80s, less than 20% have with the rule and around 60% have against the rule astigmatism. So the posterior corneal astigmatism compensates for the anterior corneal astigmatism in a younger population and increases the total astigmatism in the older population, which is important because the senile cataract cases that will be seen are the older population. So there the anterior corneal posterior corneal curvature is going to add on to the total astigmatism, and your threshold for toric may go lower. So what's the clinical significance? If you rely only on anterior corneal astigmatism, in case there is a with the rule astigmatism, you will be overcorrecting it to the tune of 1.38 times. If there is against the rule astigmatism, you will end up undercorrecting to the tune of 0.65 times. Does it matter in our normal routine cataract surgeries? Not so much. However, now we are moving from visual acuity to precise visual quality as well. We are increasingly implanting premium IOLs. They are not tolerant to any residual astigmatism. So this assumes higher significance in premium IOLs because our cataract surgeries are more of refractive surgeries nowadays. So then you have to take into account the posterior corneal curvature. Then again, post-refractive surgery cases, post-RK, post-LASIK, ectatic corneas, there is an altered relation between the anterior and posterior corneal curvature. There again, the normal ratios and assumptions do not hold true, and you have to have devices or nomograms that take into account the posterior corneal curvature. So we have well established why we should know about posterior corneal astigmatism, why we should take into account. So how do you end up measuring it? You can either assess them directly. We have devices, optical coherence tomography based devices, slit scanning devices, Purkinje image based devices, and sheen plug devices. One of the few examples are Pentacam, ILMaster 700. Then there are prediction formula for total keratometry. There are nomograms that take into account the posterior corneal curvature, including the Baylor and the Abulafia-Koch formula. Then the calculators also account for it. The Barrett toric calculator, Barrett True K that is given, and various other online calculators. In fact, all the major companies that give toric IOLs, they also have incorporated either one of the newer formulas or some method to estimate the posterior corneal curvature. So ILMaster 700 incorporates telecentric keratometry and swept source OCT to provide a total keratometry value encompassing both the anterior and posterior corneal curvature. So the posterior corneal surface is directly measured with swept source OCT. So anterior telecentric 3-zone keratometry to give the anterior surface, then the swept source OCT will give you corneal thickness at various points, and you extrapolate those points to give a posterior torus fit, and therein you calculate the true keratometry values using appropriate formula. So these are just the various devices available. So if you see, except for the manual and automated K that we were using, the newer devices, all of them either estimate the posterior corneal curvature or take it into account using some or the other formula. So which device to use then? Various devices, as we have seen, measure the posterior corneal astigmatism. So a study by Hoffman et al. Evaluated 5 different systems. What they said was that highest precision is achieved by combining the keratometry and OCT data. So Baylor nomogram is also more precise than previously used online calculators. So the rule is that leave patients with slight with the rule astigmatism to account for the against the rule shift that occurs over time with aging. So this is the nomogram for lenses. So if you have with the rule astigmatism, your threshold goes higher till 1.7. You can do away without implanting a toric IOL. If And against the rule, astigmatism is present. As soon as you get any toricity 0.4 to 0.79, also they recommend that you can go ahead with toric. The results would be more precise. So this is a Barrett toric calculator that takes into account both the effective lens position and posterior corneal astigmatism. Again, various online calculators now account for posterior corneal curvature. So just a clinical case example, this patient was planned for left eye multifocal IL with a corneal astigmatism of 0.74 diopter. So you may think you can get away with a plain multifocal IL alone. However, when you look at the true K values, it's a 0.89 diopter. So you cannot really leave alone even this minor astigmatism in a case of premium IL. As we saw with the previous speaker, glares, halos, etc. can be seen after surgery. There'll be more. Patient dissatisfaction will be more. Even though the patient may get 6666 parts, the quality will not be optimal in premium ILs if you leave uncorrected cylinder. So a multifocal toric T3 series was planned in this case. So it's not necessary to accurately measure the posterior corneal curvature with one of the devices. You may not have all the devices. What's more important is you have to compensate for it. So what Ferreira et al. Observed was that directly evaluating the total corneal power for toric IL calculation was not really superior to estimating it using formulae and nomograms. So do not be disheartened if you do not have all these newer devices. You may say that my practice runs on keratometry alone. There are a lot of online tools available. It's not important to have the latest device to measure. It is good, of course, but it's not absolutely essential. What is more important is you realize that posterior corneal curvature has a role to play. You account for it using any of the various online nomograms or formula. So just the take home message, what is posterior corneal curvature and total keratometry? It's an against the rule astigmatism 0.3 to 0.5 diopter in magnitude that remains more or less constant with age. The total keratometry takes into account both the anterior and posterior corneal toricity. Why to measure it? To avoid IL power calculation errors. It leads to not taking it into account leads to overestimation of with the rule and underestimation of against the rule astigmatism. How to measure it? There are devices that will measure the posterior corneal curvature, predictive nomograms and formula. Either method is acceptable, just do not ignore it. Thank you for a patient hearing.
Wonderful, Dr. Manpreet. So I think the last slide summarized, the importance of PCA. Just to summarize, do you think, so what is the take-home message? Posterior corneal astigmatism, yes, no? Is it very important? So even if I don't have a tool to measure it, I can still do
Yes, of course.
justice to my patient. So that's, I think, an important message to people here that, not only in cataract, even in refractive surgery, the talk about PCA in, customized treatments, customized LASIKs. I think something we've also published on the role of posterior corneal astigmatism, even in customization and refractive surgery. Well, it's a plus minus. It may not have that an important role. So I know groups in US and many other places are talking about PCA and importance of PCA, and I think she very well sequentially spoke about how you categorize what instruments you use and where and what is the understanding of PCA in our premium IOL practice. So any comments from anybody in the audience? If not, we can take the questions at the end of the IC. All right, so I think we'll move ahead. A great honor, privilege to introduce Dr. Dishita. Dishita works with us at Narayana Netralaya. She is a cataract and refractive surgeon. She will kind of simplify and simplify and demystify multifocal IOLs and extended depth of focus IOLs, and where do we stand on that? Over to you.
Yeah, thank you for the introduction. So I'm going to be talking about multifocal and extended depth of focal IOLs and where we stand with this regard. I will be talking more on the optics of these. So we know that in today's day and age, cataract surgery outcomes are measured in terms of the refractive outcomes. One of the most important challenges that we have is restoring accommodation in pseudophakia. The challenge mainly being that restoring pseudophakia is actually restoring a dynamic process. So what are our options? First, we have monovision, where one eye is corrected for distance and one for near. The second and one of the most promising approaches is the multifocal IOLs, which achieves good distance, near and intermediate focal points simultaneously. And we also have the accommodative IOLs, which provide a dynamic dynamic refractive power with contraction and relaxation of the ciliary muscles. So coming to the multifocal IOLs. So by definition, they separate light into different foci, which actually disperses energy and finally falls on the retina. So for a multifocal to function well, what it actually has to do is split the light into two foci, which comes from the near and distance, and both of them have to simultaneously fall on the retina. So broadly, they are classified based on the optical principle into refractive or diffractive lenses, and based on the optical property, they are classified into extended depth of focus and multifocal IOLs. Based on the design, the refractive IOLs are classified into zonal and aspheric, and the diffractive into bifocal and trifocal IOLs. So coming to the design of each of these, refractive IOLs, the initial design was a two-zone design in which the outer ring had the power for distance and the inner had power for near. Now the limitation of this was in bright light, obviously when the pupil constricted, distance vision was blurred. So to overcome this, the bullseye model was made, wherein the center was distant dominant region, which was surrounded by the near dominant regions. Now, the diffractive IOLs are based on apodization, in which there is a near dominant central area surrounded by concentric rings of decreasing height that result in diffraction of light at both distance and near. So the zonal refractive IOLs have different refractive power zones in the annular zones. While they provide good distance and intermediate vision, near vision is not sufficient. It is pupil dependent and the transition between these regions is blended. So the commercially available IOLs of this category are the Array Rezoom and the M-Flex from Rayner. So coming to the diffractive IOLs, they work on the principle of diffraction. It was initially introduced by a French army engineer called Augustin Frenzel, mainly to improve lenses for visibility of lighthouses. What he actually did was he removed some parallel blocks of glass, and this created a sort of a prism which would bend light horizontally. It was not actually made for imaging, but it helped in collecting the light for lighthouses. So coming to diffraction is basically the principle where light bends at the edges or at slits, and it is dependent on the wavelength, the size of the wavelength and split. If they are close together, the light bends well. What we also need to understand with diffractive IOLs is the principle of interference. So interference is nothing but the combination of two or more waves and how they form a composite wave. In destructive interference, the one crest cancels out the trough, so the resultant wave amplitude is zero, whereas in constructive interference, the troughs and the crests add up and they form a wave which is double the amplitude. So this is a principle which is used in the diffractive IOLs to create different diffractive orders, and light at each step is equally divided between the distance and near focal points. What we also need to note is a portion of the light energy, about 18%, is directed into higher diffractive orders, which is responsible for the glare and halos, and the remaining part is distributed for distance and near. So, so the diffractive IOLs utilize the principle of diffraction along with refraction to create the two foci. So the basic refractive power is provided by the aspheric surface, and the diffractive power comes from the multiple grooves on the posterior surface. So by altering the width of each of the diffractive step, we can choose whether to correct the near or the intermediate vision. When the steps are narrower, you add a higher addition power, and when the height is higher, you add more energy to the near vision. So diffractive IOLs work on the mechanism of apodization. They have a near central dominant zone surrounded by concentric rings of decreasing height. Each ring has a discrete order which creates a diffraction pattern. It creates two focal points. Usually it splits light for distance and near. And these microscopic steps have a specific phase delay, which is usually half of the wavelength. And this is based on the Huygens-Frenzel principle. Now the disadvantage of these lenses is because it forms two focal points. There is decreased range of vision, there's decreased light transmission, which means there's poor contrast with these lenses. There are multiple diffractive rings which cause glare and halos, which is a big disadvantage, and it also is compromised for near vision in bright light. So, looking at how this technology has progressed, initially it was a bifocal design with just two serrations, as you can see, and it has progressed to the part where we have a three-step height, and this functions as a trifocal IOL. When we compare the refractive and diffractive IOLs, refractive multifocal IOLs are pupil dependent. They have higher photic phenomenon but do better for intermediate vision. However, diffractive IOLs are less pupil dependent and have lesser photic phenomenon. Now, we have also moved into hybrid IOLs, which combine both of these optical principles. For example, the Acrisoft Restore multifocal IOL, it has an aspheric distance periphery, which gives us better contrast in distant vision. It has a diffractive apodized bifocal area in the 3.8 mm zone, which helps in far and near foci, and the refractive multifocal within the 1.5 zone, which helps in far and intermediate vision. There are other multifocal IOLs which are partially diffractive. The advantage of these is that in mesopic conditions they do fairly well, but the disadvantage, of course, is the glare and halos. As mentioned, there's reduced light intensity, reduced contrast sensitivity, and glare and halos, which is a disadvantage with these lenses. So, in order to overcome these, with the aim of improving intermediate vision, with the aim of improving and reducing dysphotopias and not impairing far and near vision, we further moved on into the extended depth of focus lenses. So, while in a monofocal lens there's a single focal point, and in multifocal there are two or three discrete focal points, the extended depth of focal lenses create a single elongated focal point to enhance the depth of focus. So, this introduces it reduces and eliminates the overlapping of near and far images, which reduce the photic phenomenon and provide better contrast sensitivity. So there are three distinct types of EDOF IOLs which are presently there in the market. The first one is the IC8 or the Apthera, which is based on pinhole effect. These lenses do extremely well in patients of RK and keratoconus patients because they reduce the aberrations which are formed. And the other one is the extra focus pinhole implant by Mocha. And the second type of lens is the EDOF effect lenses, which is from Synergy in Technis and also Symphony. The iHance lenses are modified monofocal lenses. So just to look into the various lenses, the Acrisoft Vivity uses the X-wave technology and overcomes a lot of the glare and halo phenomena. The other IOLs in the market are the Minivel, the Lucidis, the 80 Lara. Now, all of these lenses help us in our practice to improve visual outcomes of our patient, and that is the main idea of this talk. Thank you.
Wonderful talk, Dr. Dishita. Any comments, Dr. Manpreet, before we move ahead?
I think she presented wonderfully the entire armamentarium of options that are available now. New IOLs will keep on coming in the market. So I think one of the very important parameters that I judge any multifocal or extended depth of focus IOL is if it compromises distance. Irrespective of whatever be the near intermediate visual quality, the patient is not going to be satisfied. So before you look at the near vision, intermediate vision, visual quality, you have to see that it has to meet the parameter of not compromising the distance visual acuity. Otherwise, I think the newer ones are doing very well, the trifocals, etc., in terms of reducing the glare, halos, and dysphotopsia. Yeah.
Thank you.
Thanks a lot. It's an honor to introduce Dr. Mohita Sharma. I think she needs no introduction. Thank you, ma'am, for being a part of our IC. Press biopic surgeries, I think, it's something which is optically not very well understood. And how do we proceed with press biopic surgeries, indications? Trying to demystify the optics of that is what Dr. Mohita will be speaking on, ma'am. till it gets ready. Any comments from anybody? Clear questions? More than happy to take. This is the last talk for our IC.
So good morning to everybody. Thank you, Dr. Gairik, for putting all this together, and a very important topic, and very good speakers, whatever I have heard till now. Very, very informative, Dr. Deshita as well as Dr. Manpreet. So I'll be talking about both presbyopia correcting lenses as well as presby-LASIK. Since Dr. Deshita already covered most of in fact all of presbyopic correcting IOLs, I'll just quickly skip through and we'll go to presby-LASIK almost directly. So we know that our patients, previously when they used to come to us, they used to ask us how safe is cataract surgery. But now the focus has shifted. When they come to us, they never even talk about safety. They expect us to be doing a safe surgery. And most of the time that we spend with them is spent on what type of lens to be implanted. So it becomes very important to know about these lenses, and most of our patients now want a presbyopic treatment, whether it is in the form of a LASIK or it's in the form of IOLs for cataract surgery. So already we talked a lot about EDOF and trifocal lenses and their principles. So I think I can kind of almost skip through these. And as Dr. Deshita said, now these trifocal lenses, they have principles in which the steps are responsible for the different features of the IOLs. So this is done by altering all these lenses are playing on the step width as well as step height, and as we alter these step width and step height, we can have different focal points for different lenses. So the step height controls how the light energy is split, and the step width controls the power of the lens. So as you can see, if we increase the step width, then we decrease the power, and it starts working for intermediate vision. And if we decrease the step width, then this starts working for the near vision. And when we combine the two together, that's what our trifocal lenses are. So along with this, apodization is one feature which is important, and again it controls how your light energy is distributed. So as you decrease the step height, more light goes into for distance vision, and hence you are able to give better contrast and more light for distance vision, because contrast was something that was always a concern with these type of lenses. And now we also have this panoptic lens, which is basically not just a trifocal, it's a quadrifocal lens. And this has got something which is called the Enlighten technology, in which there is another additional step created. And this additional step is responsible for dividing the light into two parts. One part goes for distance, so that there's a better contrast for distance, and the other part comes to near, to intermediate rather, and it shifts the intermediate from around 80 centimeters to around 60 centimeters, because this is considered as a more functional intermediate vision. So instead of 80, 60 is a better suited intermediate. So that's the principle of this lens. So this is, as I said, this is called Enlighten optical technology. So talking a little about Vivity, because the principle is a little different from all other EDOFs. As again Dr. Deshita said, all these have proprietary technologies, and these are based on acrylic designs, etc. And there are again rings which are proprietary designs of companies. But in Vivity, there is an X-wave technology which consists of two smooth surface transition elements that simultaneously stretch as well as shift the wavefront, creating a continuous extended focal range. As you can see, surface transition 1 is a slightly elevated smooth plateau which stretches the wavefront, creating a continuous extended focal range. And the surface transition 2, now this is basically a small bump which is there in the center. This this shifts the wavefront to utilize all the available light energy. So this diagram clearly shows how it stretches as well as shifts the wavefront so as to give us a better quality of vision. So based on these characters, again, I'm just doing a quick review of this because I don't want to repeat the same things, but based on these characters, we decide as to which lens is most suitable for which patient. And a scientific rationale for near and intermediate distance visions is given here. So 40 to 80 centimeters is what we generally require, and 60 becomes a very, very optimal intermediate vision. So any lens which starts working between 40 and 80 becomes a lens which is useful scientifically and practically. So coming now to press by LASIK treatments, again, there are a lot of press by LASIK treatments that are available now, but I start by saying that all current and new solutions are actually compromises, and we are still trying to find out the most suitable procedure for each patient. Monovision is what we used to work on previously, but this monovision used to result in loss of stereopsis and fusion, and all these press by LASIK treatments are basically micro monovision. Since it's a micro monovision, there is no loss of stereopsis and fusion, and there is a good contrast, and these patients are actually happy patients. We've been doing press by LASIK for the last 7 years, and now press by LASIK is becoming an accepted norm, so it's important to understand a little about this procedure. So most of these procedures work on a hybrid approach where apart from micro monovision, they create a multifocality on the cornea, and you have to choose appropriate proportion of these two methodologies according to the patient's needs, and that's how the treatment is designed. Now, press by LASIK can be central press by LASIK, peripheral press by LASIK, or a laser blended vision in various machines. And most commonly used nowadays is the central press by LASIK because this is the most physiological. Now, there is a central hyperpositive area which is created, and this is used for near vision, whereas the peripheral cornea is used for distance vision in central press by LASIK. And this can be used for hypermetropes, myopes, as well as emetropes. Even for emetropes, we have done central press by LASIK, and of course, patient selection is important. But once you select your patient properly, these are happy patients because they get independent from reading glasses. So this is the principle of central press by LASIK. As you can see in the center, you can see center is reddish, and in the center we create a hyperpositive area, and there is a small bump which is created, and so this center works for near vision. And when the patient views for near, then our pupil constricts, so it's the central near zone which becomes more central 3 millimeters which becomes more active. When the patient is viewing for distance, our pupil dilates, and so it's the 3 to 6 millimeters zone which becomes more active, and in between there is a smooth transition. So none of our patients we've seen have complained of any glare and halos. Probably the reason is that here there is, though it's a multifocality on the cornea, and that was very much expected, and we were also surprised. So, but probably there is only one single ring there, and it's not a multiple rings there, and probably that's why the patients are not complaining of these problems, and they are happier patients. So it's a pupil dependent procedure. And as I said, it is more physiological, but because whenever we are reading, it's the pupil constricts and the central area becomes more active. But we have to remember that there is always a slight impact on distance vision, as some light also passes through the near zone and does not focus perfectly when the patient is viewing for distance. And hence, there would be a certain amount of line loss or decreased vision for distance, which is always told to the patient. Now, it has been seen that most of these procedures will have a single line loss for distance vision, so that's why we said it's a compromise. Out of these, one procedure which works on a little different principle is the press beyond, where there is a laser blended vision. It basically plays with spherical aberrations, and there is an alteration in the spherical aberration which is responsible for near vision, and this is combined with a micro monovision. So we can skip these patient selections, etc., because I think time is over. So just a brief about how the treatment is planned. The treatment is planned such that if it's a hyperopic patient, a bilateral treatment is planned, which means that in the dominant eye, a mild or a soft treatment is done, where a plus 1.25 to plus 1.5 power is given, and in the non-dominant eye, a more regular or a standard treatment is done, which means that eye has a near vision power of around plus 2. So dominant is always made better for distance, and non-dominant is made better for near. And when the patient sees with both eyes, the patient is a happy patient for distance as well as near. In myopes, what is planned is generally unilateral treatment, which means the dominant eye is made for good for distance, and only a plain LASIK may be done. And in the non-dominant eye, regular treatment is done, so it's made good for near. So basically, the treatment is decided by doing a preoperative simulation test, and in which we put the lenses in front of the eye, and we show to the patient what would be the actual effect after the procedure, and based on that, we decide as to which treatment would be better, whether a unilateral or a bilateral treatment, and so that line loss is minimal, and along with that, we get a good vision for both distance as well as near. So we'll skip this, but basically these were the principles of press by LASIK, and these slides are talking about the same thing. So finally, though we don't have a perfect solution, but optics and mathematics is helping us refine these procedures further, and they are here to stay, and they are already being used for many patients. So it's important to understand them. Thank you.
Fantastic. Thanks a lot, Dr. Mohita. An important point is, you told about lenticular changes, and I think there is a concept of, I think, dysfunctional lens syndrome, where you might not evidently see lens changes, but as it's a a function of a change in aberration and that contrast. Those kind of changes start quite early at 40. So, what do you suggest? An eye trace, or even if we don't have an eye trace, how do we, decide whether you're going to do a IOL or you're going to do a presbyopia?
So even if there are early lenticular changes, we would advise a cataract surgery with one of the presbyopia correcting lenses, and better is not to go for presby LASIK. But if it's absolutely a clear lens, then it's best to go for presby LASIK. And when we go for a presby LASIK, as you already said, there is a concept of dysfunctional lens syndrome, and if we have access to eye trace, it is best to actually see how your lens is functioning and see whether presby LASIK will work or not. But if you don't have an access to eye trace, then also another thing that we are doing is we measure the aberrations, and we check how the aberrations are, because again this will affect the post-operative result. And so these two things become an important thing for assessment.
Thanks a lot. I think we've just completed our IC, overshotted by a couple of minutes. I think that's okay. Before we hand it over to the next session, can we just have a small photo session for all the instructors?